So let's get started with today's clinical topic. I'm excited about this one because this is a topic that we get a lot of requests for. And our speaker today is a real expert, and she is extremely experienced in the field of dental education. She was formerly a professor of dental hygiene at Pierce College and an affiliate professor at the University of Washington School of Dentistry. Kathy Bassett has presented hundreds of clinical education courses locally, nationally, and internationally on local anesthesia, expanded functions, and myofunctional and sleep-related breathing disorders. She has nearly 40 years of experience in dental hygiene. Well, that makes her just a kid in my book. But experience in hygiene, general practice, specialty practice, and dental education. And she's got some really great and unique insights on successful local anesthesia that's going to benefit both the patient and the dentist. And so today she's going to talk about the mandible. And let's turn this over to you, Kathy. Thanks for joining us today.
Thank you. Thanks for having me. And hopefully we've got a screen share there, I think.
Yes, we do.
Okay, and
Angela,
we got it. Even in the 20th century, hygienists, really do have an integral role in that patient communication and treatment management. So for all of the young ones that don't quite get that yet, I absolutely punctuate your point that we do need to be part of that. And longstanding, even some of us older hygienostauruses, are still really active in that realm. So thank you for that call out there. So to start with, thank you for inviting me to come. And this is actually a return visit to Glidewell. I was able to come down a few years ago and actually do a few Chairside Live episodes. And I'll actually, highlight one of them today that I think can be of interest for this topic. So to get started, the first off here is get the business out of the way is I declare that I do not have any financial interest related to the content in this presentation today. Next, I'm going to invite you to grab your phone or your screen capture tool. And for the next 3 slides, I'm going to show you the 6 articles that I think are just kind of like must reading and are the backbone of a lot of what I'm going to talk about today. And then also the title for the first Glidewell Chairside Light episode, I think, is of use. So here's the first group of 3. So grab those. And I'll just pause for a few seconds. And then here's the second group. And then here is the title of the Chairside Live that's directly related to mandibular anesthesia. And you can even just Google Chairside Live episode 80 and it will pop right up for you.
I can put it in the chat as well.
Awesome, thank you. So here's the tasks today, but beyond my goal of this list of objectives is for you to be able to describe, identify, apply, contrast, and visualize things you likely already know, but from the viewpoint of unconventional wisdom. So I've just, really kind of rethought what I've seen and observed and experienced clinically. For each local anesthesia treatment plan, here's my checklist for getting started. Is first, I am going to choose articaine, particularly due to its lipid affinity, its multiple metabolic pathways, and importantly, its short half-life. Next, I consider the implication of the pH in both the drug and the surrounding tissues, and the goal is to enhance lipid affinity for anesthetics. And for me, rate of delivery matters for patient comfort and for safety. And then there is the destination or our targets, which is the primary intent of this presentation, and particularly those related to mandibular anesthesia. So to successfully get people numb, we need to consider the nerves and the tissues and the environment we're working in. So this takes us back to basic neuroanatomy, axons, nodes of Ranvier, and we need to put enough drug in the right place to surround the nerve fibers and with pharmacological properties that can efficiently pass through the membranes at these gaps. And I just particularly love this photograph because it just, really allows you to see that. And, so just really imagine, that drug needing to target literally in those little pinched areas. And if we don't get it there, we just aren't going to be successful. So remember that nerve membranes are made of proteins and lipid. And so when we enhance protein affinity and lipid solubility, then you also will enhance diffusibility, which then enhances onset and also can help sustain the duration of that anesthesia. So we're familiar with bupivacaine being a long-acting drug because of its protein binding capacity in nerve membranes and particularly at the sodium channels. But it's important to note that articaine also has a very strong plasma protein binding capacity. And then again, this will equal more efficient protein affinity in those sodium channels. And then again, results in efficient uptake of drug in those locations, which again enhances both the duration, but also, how profoundly numb the patient experience will be. So in many situations, the use of articaine alone reduces the number of challenges we encounter. And I think, particularly as we're doing more supplemental articaine infiltration, a lot of people are really registering that as, that just really helps me get through those challenging cases, or, intercede when I have incomplete anesthesia. But then what do we do when things just don't go smoothly at all? So I want to talk about a little bit of pharmacology before we look at targets. So generally, is your first response to give another cartridge? They're not numb, let's just give them some more. From the standpoint of the pH in the tissues and the drugs, repeated injections, especially with the use of vasoconstrictors, that will sustain low pH in the tissues at target sites. And then this exponentially decreases the available neutral base ions to pass through new membranes. So we're kind of shooting ourselves in the foot by actually limiting the success of successive injections when we are doing additional injections in same locations with the presence of vasoconstrictors. And this chart just shows the pH for local anesthetic solutions with vasoconstrictors in them. So simply put, the higher the pH on that range, the better the absorption through that nerve membrane is going to be. So whether we're selecting that because of the inherent pH of our selected drug, or we're deciding that we're going to buffer that, because it's important to remember that 99% of the drug in solution in that cartridge is non-lipid soluble. You only have 0.004% that's lipid soluble initially in solution. And then once we introduce that into the tissues, now we are also competing with the normal hemostasis of the pH of the body. And so there is a benefit to buffering. There is, a benefit to paying attention to the pH in those tissues, both in just normal everyday use of your anesthetics, as well as when you have challenging situations where infection is present in those areas you need to be. Which brings us back to the simple phrase of enhanced lipid solubility is going to enhance diffusibility, and that's going to get drug through the membrane. On this chart, in the lower left in the green numbers, that is as is in the cartridges. So that's how low the pH is. And note that all of those drugs in their normal pH in the cartridge are acidic enough to cause demineralization of enamel. The blue numbers represent the range of values that we see after we've buffered solutions, or if we're using a high pH drug before we administer a lower pH drug, again, to help favor that higher pH in the tissues. But you'll clearly see that we're, achieving pHs above that of normal saliva, which again, we rely on for remineralization and buffering in the oral cavity. So leaving the little bit of pharmacology, I want to touch into some histology here. And now let's look at the pterygomandibular space. So all of our conversation, today is contained in that small region of the pterygomandibular space. And the distribution of adipose tissues, the fat cells, are much denser at the height of the condyle. And that concentration decreases as we move down towards the mandibular foramen. So the presence of these fat cells favors that lipid solubility and the behavior of neutral base ions to be able to actually move efficiently through nerve membranes. So at this level, we actually have an enhanced diffusion through nerve membranes. And again, that is going to result in a faster onset and better anesthesia when administrations are at that higher level. Here's a cross-section of the tissues at the height of the Gow-Gates nerve block. And this is originally a slide of Dr. George Gow-Gates, and Mel Hawkins in Canada graciously has gifted me the opportunity for this next this pair of slides here. But what you really see is you can just see all that dense adipose. So way to the right, where number 1 is, that's your cross-section of your lateral pterygoid. And then the darker areas are the small arterioles. So you can see that the blood supply distribution is fairly confined in that area, but the density of the adipose tissue is really thick. And then again, that favors holding drug in the location and keeping it there throughout the diffusion of that volume of solution. So now let's look at the next cross section, and this now is at the level of the mandibular foramen. So here is generally our target area for an inferior alveolar, particularly a traditional inferior alveolar injection. And now you're just not going to see, that density of fat cells. You see larger arterial spaces, larger venous spaces, and now the image to the right, that is a partial section of a piece of the medial pterygoid muscle. And again, lots of microvasculature. And keep in mind that when we're doing our aspiration process and you have a positive aspiration, mostly you're picking up extravascular blood from small microtraumas to that microvasculature. It's really not that common that we literally enter into the veins and the arteries. Number 1, veins aren't really pressurized, so generally they're kind of collapsing. They're not rigid, and easy to move into. And remember, arteries have their own contractile tissues, and they're, not just waiting for us to stab into them. They're going to be able to kind of deflect away. So mostly what we're aspirating is, happening around those structures. And then that also changes the pH in that tissue by actually decreasing the pH. And then again, bleeding in the tissues is going to make anesthesia going to be more difficult to achieve. So in contrast, consider the distribution of the fat cells at the height of an IA nerve block, which is down here in the red circle. And then let's move up to, if we're doing a Vazirani Akinosi, we're going to be a little higher. Now we're starting to see a little bit more density of those fat cells. Again, that enhances onset of anesthesia. And now let's look at what that distribution is up at the location where we intend to administer that IA block. The Gow-Gates block. And it's a much denser tissue in there. So one of the things that really favors the success of Gow-Gates nerve blocks is the nature of the tissue at the site of deposition. So usually when I say controlled rated delivery, I'm talking about the use of C-clad devices. However, this principle of controlled rate delivery applies also to all manual delivery habits. And I found this research really fascinating, and in particular, because if you note, one of the authors of this paper actually is George Gow-Gates. And so this was a whole nother discussion, from him, other than, how high we're giving that injection. But here's the points that were made. So first, the faster you deposit solution, the greater the hydrostatic pressures exerted on tissues. This is the injection, the fluid dynamics exiting the needle. And this may reduce the retention of anesthesia in the area. What they found was if you deposit the equivalent of approximately 1 full cartridge in less than 20 seconds, just bam, the pressures exerted on the tissues will increase 32-fold. And that shift is from approximately 0.2 to 9 psi of pressure exerted directly on those small capillaries. And then what they noted was anesthetic may be lost through the capillary walls, reducing concentrations available in the space. And therefore, if we reduce the available anesthetic, we also likely have this contributing to partial or complete failures. So for me, the takeaway is if you're going really fast, that the anesthetic may literally be blasted into capillaries through the capillary walls, and then it's just swept away from the environment immediately, and then we don't have the benefit of that anesthetic moving forward. So this brings us to the primary YIP target today, is really looking at tissues, targets, and techniques. And so I have quite a few dissections as we move through this. So if anybody has difficulty with that, just know there's plenty. But also I find them really fascinating, and I think they punctuate points that oftentimes we don't get to see or really think about. So hopefully I'll weave a coherent story here as we bring these all together. So most of us can recite this description for an inferior alveolar nerve block in our sleep. Number 1, place your thumb or finger in the depth of the coronoid notch. Insert the needle adjacent to the pterygomandibular fay at a height parallel to the middle of your retraction finger. I'm kind of surprised there isn't a dental rap song for that. Next, when we look at this on the bony structure itself, the green curvature shows the depth of the coronoid notch. And at that deepest curvature, where we've rested our retraction finger, that puts us a little bit above the mandibular occlusal table. You can see we've moved right up the external oblique ridge. And I'd like you also just kind of pay attention to that space between the external and internal oblique ridge. Then on the medial surface, again, there's our line depicting that deepest curvature of the coronoid notch. And you can kind of see how it sort of, intersects with the superior extent of the the internal oblique ridge. And that generally is thought to mark where, in fact, the mandibular foramen is. And so that was the model that most of our injections, at least we were initially taught on, and many people still base their site selections on. And also, as commented, just, keep this area in the back of your mind as we go forward. I'm going to come back and talk more about that retromolar triangle space towards the end. So now I want to look deeper into the tissues, and let's consider the conversation of height and depth for where we think the mandibular foramen is, and why we're inserting in the manner that we're choosing to. As for depth, in this image, we can see that the mandibular foramen is located approximately half the width of the ramus when you're at that narrowest aspect of the ramus. So again, keep in mind, and each time you see any of these pictures, look for where the mandibular foramen is targeted on the image. And then what you're going to see is it essentially always is showing up approximately half that distance. Now let's isolate the superior region of the pterygomandibular space. And I'm going to be working from the top down. So starting at the dotted blue line, this is where we've sectioned off the superior section of the ramus. And this has then been cut off just below the condyle. And we're literally just below the TMJ capsule. There's all the fascia that tethers the capsule. Here's where we could get to clear bones. So we've sectioned out, and that is still articulating in the TMJ joint capsule. And then the next thing I want you to note is right here. That's the area of when we're giving a Gow-Gates injection. That's our target. So we were targeting to make contact with bone on the medial surface up at the condyle. And right here is the area where the upper portion is in fact the mandibular nerve. And then we start over here, and now here we see where the inferior alveolar nerve is coming down. You can see the superior and inferior aspect of that. And then below that, you can see the purple pin. And then if I can bring your attention right here, we're separating two structures. And that little branch there, that's the mylohyoid nerve. So in most of the dissections that I've observed, we'll find that the mylohyoid nerve, it's traveling tethered to the inferior alveolar nerve until just before the foramen. And then it branches off. And in some cases, it will be, more independent. In other cases, it will then integrate into the fascia tethered to the medial wall of the ramus. Here again, we have right in the middle, there's our mandibular foramen. And back here, so the right is our anterior, the left is our posterior. In the yellow circle, that's where our needle tip ends up in a traditional inferior alveolar injection. We move forward, we make contact with bone, and here's where we are. And again, look at where it is in context of mandibular foramen, traditional area where we make contact with bone. And also remember that the reason we can see all these structures very specifically is we've cleared out all of that fat tissue and all the connective tissues. So all of that material that then has a high affinity for the lipid affinity of the drugs, that's what we've cleared out of there. So the rest of that would have all been filled in and around with that mass of adipose tissue. So here in this pair of pictures, now I want to talk about the depth of penetration. So if we know that the mandibular foramen is in the middle of that narrow aspect of the ramus, now let's look at where, our needle insertions go. So on the left, for a 25 millimeter insertion, so long needle, we're inserting approximately 3/4 the length of that long needle to, again, make contact right here in that yellow circle. And then on the clinical side, we're seeing approximately that much of the needle exposed. Now I want to look at that same structure from the other side. So orient yourself, standing on the tongue, looking out laterally. So I'm looking now at the medial surface of that ramus. Here's our mandibular foramen again, approximately right in the middle, anterior to posterior. Wrapped around the back is the parotid tissues, which, remember again, wrap completely around the back of the ramus. And so when we encounter them, they're tucked on that medial side of the ramus. And then here's where our needle target is. For a standard inferior alveolar injection, here's where we're intending to make contact with bone. So in this discussion, as noted, the challenge with an IA nerve block is that the needle may pass both below the foramen and the nerve. And then when we make contact with bone, we are both below and behind the nerve and foramen. And in the Curry and Townsend article, it suggests that 80% of depositions with a traditional approach end up putting the drug below and behind the foramen and nerve. And this is, right here at that level of the circle. At this location, gravity isn't going to help you. And so to think in terms of I'm going to sit my patient up, let them marinate for a few minutes, and then we'll go to work, that isn't going to do anything for us because the drug is already out of the scope of gravity benefiting us. And also, this is pretty dense connective tissue in here, and it isn't an open space like a jug of water where that solution can easily move from one place. It has to move through those tissues. And then in that process, we actually do, lose some of the volume of that drug and its availability to anesthesia. So we all were taught advance until we make contact with bone. But why are we making contact with bone? And for a lot of people say, well, this is my deposition site. And my question back to you is that the best deposition site? Or is it just the fact that we've, bisected an angle and now we have contact with that resistance? And this, doesn't determine the site. And what I, really propose on this is our intention to do this is really about safety. So if the yellow lines are traditional angles, then the blue lines, this is where you end up when you swing the barrel too anteriorly. Maybe you have somebody with a really narrow face, or you've made premature contact and you're trying to adjust around it. But then what ends up happening if you don't come back is you essentially just go right out the back door, and immediately behind you is that mass of parotid tissue with the facial nerve moving through it. So our intent here is really think of that contact with bone is that's a safety check for when we are making deep insertions. That just helps us, be sure that we do stay out of that mass of parotid tissue. And again, the possibility of encountering the facial nerve, which I've seen. And if you ever have had that happen, it looks like the patient has all of a sudden had a stroke right before your eyes, and it's quite intimidating until you really kind of gather up what's happening. And then it wears off, very, very well, but it's intimidating for the patient and everybody else at chairside when it occurs. Another thing, just, for context, is I am aware of a case where the needle actually did bypass the ramus, pass through the parotid tissue, which is basically removed here, and they did enter into the carotid artery. And the way it was reported to me is they did, in fact, watch the patient have an actual stroke in the chair. And again, that's, just none of us want to be in that situation. So, think of it as a safety check, and moving significantly posteriorly or past the ramus, can present difficulty for everybody. So we all have read the articles, we've heard different speakers, we defer to our own experiences, and it generally is accepted that we miss 20% of our blocks. And in the Curry and Townsend article, they suggest, again, that 80% of depositions are both beyond and below the foramen and the nerve. So let's go after that 20%, because to our patients, it really does matter if we can get that. From here, I'm going to discuss factors related to this group of injections. And so I'll pretty much work through them in order, features around Gow-Gates, Akinosi, what called high block techniques, and I'll kind of define that a little bit, the use of a short needle for the inferior alveolar injections, and what I just refer to as retromolar and PDL rescue injections. So this is going to ask of you to just consider some different perspectives. Hopefully these are some things you might not have really thought about, and just making a little bit of a shift in technique related to that can go a long way. So the first paradigm shift to consider, really is it relevant? Is it irrelevant? And I'm going to be integrating anatomy and the alternative approach to what you could do simultaneously. So at the blue circle, this is at the common target for what we refer to as just go higher. And so, kind of what happened when this 20% of failure kept coming again and again and again, some authors started, really publishing about doing a high block. Well, there's, are you going to do something higher, or are you going to do something better? And what, I really think is that this is the first place we should always go. And I hope that I demonstrate, the value of really those insertions that move us up from what most of us, again, were traditionally taught. What you see on the right is the paracurvatures. The lower curve down here, that is the height where normally we were, mostly taught to give the traditional Halstead block. The higher curve is kind of the target area that I'm going to encourage you to migrate to as your normal insertion site. And then I'll show you a few soft tissue cues to be able to find that easily. So here you'll see one of my favorite quick tips. So as I go through, anytime it says quick tips in the title, you can pretty much find the background information from the articles that were given to you at the beginning of the presentation, and then a few other things that I've just amplified those as I go. But a quick tip, generally you can get back to the reference and dig into that some more yourself. And this is one of the gems. that the traditional IA nerve blocks are taught with needle insertions that are approximately 10 millimeters above the mandibular occlusal table. But in the Gow-Gates research, they demonstrated that 94% of the time, that foramen is actually 15 millimeters higher. And so just even that shift of 5 millimeters could allow you to capture 8% of your missed blocks with a shift of only 5 millimeters. And I think that's actually pretty cool. And again, 94% of the population, those foramen are actually found higher. So for the Gow-Gates technique, we're going to move up to this higher target here. So this is putting us up at the junction between the anterior and posterior branches of the inferior alveolar nerve. So here our goal is to capture more nerve branches with a single insertion. And we need for that to note that the buccal nerve actually comes off this anterior branch. So here's the blue circle on the right. That's the area where we're going to deposit our solution. And that's right at the level where you're going to have the buccal branch come off and make its way down medially, and then again cross over the ramus at the retromolar triangle area. And all this area is surrounded by dense adipose tissue at that level. So for the Varanzi, the Varanzi Akinosi, now we're kind of between those two sites. And for this one, your insertion is you're pretty much parallel to the maxillary occlusal table. And often this is injection that is, found in favor for patients that have limited ability to open their mouth, or maybe you've got a lot of soft tissue distractions, a profound tongue, and it's just hard to navigate. And you could, use this to be your approach to capture that IA, or at least get some pre-anesthesia that may allow you to get into that space more easily. And in some places around the country, this is actually taught as the first choice, the primary injection with hygienists for scaling. And here's the two tips that are, really helpful to just be able to do, this very easily. First, start with the famous close your mouth slightly and shift your chin to the right position. So, have them close and shift. Open that space so you have room to establish the barrel of the syringe in there. And then once you've done that, you're just going to line up the barrel along the mucogingival junction. You're just going to insert in a straight line until the rim of the hub aligns right over the buccal groove of the first molar. You may have to account if there's any missing teeth, but those are the primary alignments. And then the other thing is to be sure to orient the face of the bevel towards the teeth, because with our basic physics, needle tips move away from the bevel. So if I orient the bevel towards the teeth, as I insert, it's going to turn the bevel towards the ramus and make that internal curvature. Some people like to bend the needle to do that. I'm not a big proponent of bending needles for any purpose other than maybe a PDL, but when you just use that principle of physics, it's going to make that same curvature all on its own at the depth of this insertion. So this is an example of a family that might actually benefit from the Vazirani Akinosi technique, just saying. And this family holds the world record for the widest tongues. And the dad's tongue is approximately 3.5 inches wide, and his daughter's tongue is approximately just under 3 inches wide. And if you want to dig into this story a little more, you can just go to kids' world records at the Guinness Book of Records. This brings us back to the discussion of depth of needle insertion and to the question of the use of a long needle versus a short needle for an inferior alveolar injection. And for some, you almost feel like, you're being sacrilegious to even propose a short needle. But I'm going to show you, some data that reasonably is a reasonable rationale for the choice of a short needle. And this is out of the article again from Minky and Gow-Gill, and they actually proposed that short needle insertions will more accurately put anesthesia close to that inferior alveolar nerve above the foramen. And again, the more volume we have at our target nerves, the better, anesthesia outcome we're going to have. And then also, I'm going to weave that into the discussion by Curry and Townsend that the higher penetration and the use of a shorter needle is going to both solve the problem of being below and behind your foramen. So again, this gives us an opportunity to solve both of those challenges at the same time. So the key points are the depth of the foramen is at half the width of the ramus, and that puts us right here at the orange circle. Again, at half that width of the ramus, and that was replicated on your greater than 200 samples in this research. That means that the mean depth from insertion to the area of the nerve is approximately 16 millimeters, and that's well within the length of the average short needle. And so we traditionally use a 25 millimeter short needle, and so we've got it standardized. We always use that needle. And so, we're using a common measurement, and I easily have, approximately 6 millimeters, still available after that insertion. So here's what they look like in place. So note the foramen is at half the width of the ramus with a depth of insertion at 25 millimeters, at 19 millimeters of a 25 millimeter needle. And that puts us right here inside this yellow arrow. There's our short needle insertion. So on the right, here's what it looks like clinically. And we have approximately 4 to 6 millimeters. And that's our reference point. We use that calibrated needle and we insert till we have, marked that estimated 4 to 6 millimeters. And that's the depth that we use for everybody. And you'll see here in the arrow here, there's the needle tip, and we are right at the foramen, right adjacent to the needle. And also, we aren't going to move past it. We aren't going to move through it. We aren't going to move past it. We aren't going to trap it and bump it against the bone as we make that contact with bone. And one of the favorite theories in the discussions of paresthesia these days is it's a trauma-related event. And we're finding that nerves can be drugged through space. They can be pinched and bruised against bone. So if we don't need to go that far and risk those encounters, and at the same time, put an adequate volume of solution, immediately bathing that nerve, then we have 2 or 3 win-win situations all going together. One thing I do want to say is that I never advocate for the use of 30 gauge needles, and particularly for these injections. I'm okay with a PDL, but for these deeper insertions, and I just like that feeling of particularly a 25 gauge needle. 27s, they're okay, but that just kind of, sense of rigidity and really knowing, feeling where I'm at, I think is beneficial in these injections. Personal opinion. So when you pair this with a higher insertion point and short needles, they're going to provide reliable anesthesia. And so each of these 2 animations is just kind of a little visual to help you think about more superior insertion points, which also, by the way, are less likely to have bony obstructions, premature contact on the way in. So on the first one, the dark green dot, that's the location of the traditional Halstead block. And what I'm proposing is that you walk your way up along that refait to that level of where that bright green dot is. And I'm going to show you 2 ways to routinely find that quite quickly. So here on the right, just watch. I'm going to start with that cotton swab, literally tapping on the retromolar triangle. Because remember, I showed you the bone in the beginning. So I start tapping on that bone, and then I just walk back until I literally fall off past the internal oblique ridge. And it just puts me in this deep, squishy area. And see how much higher I moved? And it's very, very soft right there. And then a couple of things I can do, to help me find that is, number 1, remember that your cotton swab is one of the most important tools on your tray. And then the next thing is just think of it like a hammock. So when I am palpating through that pterygomandibular fold, I'm going to go until I find its deepest part. It's just like the butt of a hammock. Just palpate, find that deep soft spot, and lo and behold, it's going to put you routinely right here. And we kind of refer to this as the dog leg. And so this next week, I just challenge you with every patient you see, just on glance alone, see if you can find this target, even without, picking up a cotton swab. And so we're talking about this curve, common to the hind leg, of a dog, and you have this bend. And what you see is this part comes down off the soft palate till this junction, and then there's an obvious little turn, a little, bend at that dog leg. And so if I don't even pick up a cotton swab, I'll just visualize for the dog leg junction and I'll go there. Or I can palpate to that deepest area and go there. The other thing about that, on that cue is then on the medial side of the pterygomandibular fay, that's also the junction where the soft palate, the velum off the soft palate, merges into the raphe. So you come off the curvature of the soft palate, and then you're all obviously right here dropping across to the oropharynx and that little bend. And if you just go right there for all your injections next week, I anticipate that you'll have some successes that you may have been worried about otherwise. The other little analogy that we use is be close to the raphe. Don't wander buccally towards the bone, just snugging close to that raphe. Remember, it's flexible and moves like a clothesline. And we can actually manipulate it, but it's as if you were inserting into the depth of a taco. There's just this folded tissue, and just imagine you're aiming right for the bottom of that little taco shell. So at the dog leg, the bottom of the taco shell. And then I'm going to suggest that right after you insert the needle tip, just gently deflect the raphe towards the tongue. And what that's going to do is just gently move soft tissue off the bone. So then you're less likely to have premature contact on internal oblique ridge, less likely to have contact at the lingula. Another tip, and this is out of the Blanton and Jessics article at the beginning, that's a great article on who would have known, thoughts about anatomical variations. And so what they have demonstrated is the buccal nerve is actually higher and closer to the maxillary molars as it crosses over the front of the ramus when the mouth is open wide. So when we give that buccal infiltration, if we're putting it down in the corner near that distal buccal cusp of our terminal molar, we very well are below where that nerve comes over when our patient's mouth is open wide. If I have them closed, like for an Akinosi, that could be exactly the place. But in cases when I've asked them to open wide, which is going to be our IA and going to be our Gow-Gates, I need to be thinking about coming more superior and more lateral to make that penetration. So how you see it, how you don't. This is, kind of looking at, considering these are some unconventional solutions to problems you likely see on a regular basis and may have a partially successful intervention for them. But here's some other suggestions that you can try. So to start, the injections for osseous targets, these are very effective. Just remember, drug moves through spony walls easily. Your visual cue on this one is be sure you see blanching. So this is going to tell you you have an appropriate location, and this is going to tell you you have an appropriate volume of anesthetic. And just remember, it's going to flow through all that cancellous bone. If you have troubles determining the site and making entry into that space, biggest cue is just pick up your probe and find that angle. Hygienists are awesome at this, but it's the same angulation as if you're probing that tooth to make those insertions for successful PDLs. On these images, I want you to just look for proximity of the distal the proximity of the roots of the molars to the inferior alveolar canal. So on both sides, here's our canal. And right there, look how close it is here versus the distance here. So on these next images, just observe for a moment for the proximity between the roots of the second molar in particular and the canal. Look how close that is. In this one, you can actually see, you can actually see the apex into the canal. And so what we've learned is that you can capture an incomplete IA by simply giving a PDL on the second molar. The solution goes directly down, passes into the canal, and you can actually, add that additional anesthesia for the IA at that level. It doesn't work with all the time like any of our other solutions, but we found this to be very effective, and you need to target the second molars to do that. The other way that many of you are very likely when you do an implant work is to be prepared to do an intraosseous if you need to. And traditionally, these require some additional device to accomplish this. However, we can also accomplish this manually with a technique that is being pioneered and discussed by Dr. Greg Tuttle in Utah. And I've had the opportunity to do these both in a cadaver lab situation and clinically, as well as receive one. And it really is quite easy to do. And the most important learning for me was the understanding that when you're choosing your insertion site, we're literally using the gingival margin as our line up for that. But again, once you get the injection in there, very limited resistance to that. For this, there's a lot of text here, but here's the punchline. Many of us have networks of accessory foramen in the mandibular retromolar region, and the inferior alveolar neurovascular bundle that can innervate the teeth actually within the body of the ramus and that retromolar triangle. This network has a communication between the mandibular canal and the retromolar triangle. And so you can see here where we've threaded a wire through this, and here is that retromolar foramina. Here's where it entered right into the apice, right at the apice of that terminal molar. It's kind of like a secret back door that doesn't work to our behavior. So again, on these next 3 images, just watch for foramen you don't normally think about, like here, here, here. Neurovascular bundles enter all of those spaces. Here, here. Again, neurovascular bundles. It can be buccal nerve, lingual nerve, mylohyoid nerve. All can have small fibers entering into that location. And this is back to that original picture. And so if we have nerves entering here on the surface of the retromolar triangle and they're coming out down here to our apice, then we need to target within that space. And so our 2 locations is there's our retromolar triangle, and right here, that retromolar pad, and looking at that soft tissue. And this is a pretty easy solution. Literally, we're going to have you just turn the bevel down towards the bone and just make an infiltration right over that foraminal area underneath that pad of tissue. And we can see a really strong response to capturing some of those, teeth that just aren't settling down. In the Suezo article in the resources, they discuss the site for an inferior alveolar nerve block. And they do it when there's contraindications related to bleeding disorders, and they don't want to use deep needle insertions. In that research, they showed 75% success rate in achieving a mandibular block at this site. And they just gave it really slowly. The use of C-clad devices is awesome for that. And they literally just make that insertion and very slowly deposit the same volume. And again, 75% success rate. That article's in your resources. And in the Blanton and Jessic's article, they stated that we have 60% of the time we have innervation from the mylohyoid nerve. Again, those fibers can enter in through the wall. So even if we do this particular injection, that is, kind of the common one that is discussed, that infiltration. Number one, we have to make sure the floor of the mouth is numb from the inferior alveolar nerve. And in this case, if it's entered into the bone, that might not be as efficient as doing that infiltration directly under the cap of the retromolar pad. And the last couple of things I'd like to share is this is also a time that myelohyoid infiltration can be critical. And with a more common approach at the distal of the tooth of distress, then we can capture, those. But look at the image on the left. And what we can find is that both of these infiltrations can be applied for individuals presenting with this anomaly. And they are 3 rooted mandibular molars. And this is a common anomaly within the indigenous community and South American populations. And I was introduced to this phenomena when I was teaching dental therapy students in Alaska. And some kind of a myelohyoid injection was critical, in their techniques in armamentarium. So thank you for inviting me. Those, in fact, are my favorite mandibular tips. And again, appreciate the invitation. I think I'm coming back in March. So we'll do some more discussion on the maxilla. And if you missed the resources, if someone would just let me know, I can put those images up again.
So thank you so much, Kathy. It was a great lecture, really, really good illustrations and very, very orderly. We have a ton of questions, so I think we need to just hang in there and Nicole, can we give them extra CE for staying with us through the
Absolutely.
Q&A?
Yeah, we'll bump it
Okay,
up
let's
to
do that. So
1.5.
we'll bump it
Depending on
up
the
to
time.
1.5. Okay, are you ready, Kathy? We're going to come at you fast and furious.
This is like,
Ready?
yeah, rapid round. Go.
The wrap around.
Okay, so when you started with your
fast enough already.
pharmacology and you showed your illustrations of the different pH levels, I mean, it looks like we should be buffering. So is that clear?
Yes.
Is that your recommendation? We should all be buffering?
I think there is strong evidence that buffering on a regular basis is going to improve your patient situation, which improves your case acceptance rate. And I also believe that we're going to have more options of how we do that. Technology is just shifting and changing. And so, yes, I encourage everybody to do that. And in the meantime, if you infiltrate first with approximately a half cartridge of mepivacaine plain, it has enough of a pH difference to boost it a little bit. And then that second injection, particularly with the vasoconstrictors, can be more successful. So that's, kind of the poor man's buffering. But yes, buffering is awesome.
I like that.
Okay, good. All right, great. And then you seem to indicate that articaine was the anesthetic of choice. Is that, did I get that right?
It truly clearly is, in Europe, it has been for many years. We've only had it in the US about 20 years. So we're still, getting out of our comfort zone, but there is really valuable pharmacological information. And the biggest things, really are, it's got a half-life of 15 minutes to 45 minutes for a whole cartridge of drug. So in anybody, particularly that has organ compromise that inhibits metabolism, when you're talking with individuals, pregnancy and nursing, and we want to reduce that drug load quickly, articaine is just awesome. And the other thing that's important for everybody, articaine users and others, when you read the insert, it recommends right in the drug insert, start with 1 to 200,000 vasoconstrictor. It has been demonstrated to be just as effective for establishing anesthesia. Now, when you're doing surgical cases, you need hemostasis, then you may benefit from the 1 to 100. But for a basic pain control regime, 1 to 200 is the initial drug of choice for that. And then again, that leverages a lot of how much drug you can give with people with cardiac compromise, because I'm only giving them half as much epinephrine at all.
Right. One of our doctors wrote it, and he said that in Ontario, they're recommending not to use articaine for blocks because of incidence of long-term paresthesia. Do you want to comment on that?
Because of really old research that's been disproven so many times that the European equivalent of the FDA won't even entertain the comment anymore because that has been so well refuted. And there's some pretty current articles within the last year, really taking that away. Again, the issue really is more around physical trauma to nerves, in which case all of our drugs can have some impact. Our 4% drugs could have a higher impact, but they're really believing that there's additional physical injury to the nerve that precedes the exposure of the drug.
Very good, very good. Here's a good question. I mean, how do you find your landmarks in obese patients, where some of the basic anatomy looks different?
The hammock, because even
Okay.
if you can't see, you can feel that space. And then in which case I may need to have, somebody come and assist me to hold that tongue so I can maintain it. But the reliable is I can always feel that hammock curvature, even when I can't see my other, useful visual cues.
Okay.
And again,
Okay.
go
And then we
higher.
did have a question about the tongue blocking access. So sometimes you have to bring in another professional to help you
Yep,
manage your
yep.
tongue. Gotcha. What
Particularly with a
about
block.
this doctor? This doctor has noted that he or she has more difficulty numbing diabetic patients. Is that an observation you're familiar with?
There is, well, a couple of things. It's sort of, a theoretical grouping, and it can come back around to tissue pH, but we do find that people, for different metabolic reasons, it can be history of drug consumption, history of alcohol consumption, other medical things that do in fact shift the pH. So one thing I would try is, if you aren't already buffering, try buffering with those individuals and see if you can make that change within the tissues, because that may actually be what's happening. And also, fear, distress, epinephrine all stimulate the release of glucose. And now we've, started the whole metabolism process. So it just might be that they have a little bit of accelerated metabolism in there and are breaking that down more quickly. Or on the front end, they just don't get numb because of a variation in the pH of the tissue to start with.
Okay. And have you noted anything with the use of certain drugs or marijuana, medicinal or non-medicinal, affecting the ability to render anesthetic?
I'm aware of the articles. I'm aware of the discussion. Personally, I don't know that I could, state on saying it, but in one of the 88 articles within the past, I think maybe year and a half, they said that we should anticipate that 50% of our patients are intoxicated with cannabis when they arrive. And so it's like, do I only think this when I know the person has consumed cannabis? Or am I observing this on a large portion of my patients if I think half of them aren't telling me they've had cannabis before they came? So it's an
Right.
interesting curve. But my biggest thing on cannabis is watch for tachycardia. It can have a profound impact on elevated blood pressure, elevated heart rate, in certain individuals, particularly, certain groups of young men. And so that can end up becoming the problem, not the metabolism of the drug.
Got it. Got it. Okay, you made a really nice recommendation for the 25 gauge needle. And what would be the basic length of needle that you recommend?
If you can find the 25 millimeter, and there's at least 3 brands that I normally, luckily when I went and looked up the 3 we normally use, they all were 25 millimeters in length, readily
So
available.
25 by 25.
25 by 25 gives you,
Wow, couldn't be
stability,
easier.
and, it gives me that reliable. I always know I have 4 to 6 millimeters of wiggle room.
Okay.
It can
You
easily
mentioned
see.
the bevel a couple of times. And so which direction should the bevel be facing as you enter the tissue?
So just keep in mind that the needle will always move away from the bevel. So if I just think about where is it I'm trying to get my needle tip to go, then I can actually use that to help direct. So with the Akinosi, if I'm lined up with the bevel towards the teeth, then it's going to drive the needle inward. And so it's going to turn around the ramus. And there are people, like I said, that'll bend the needle and they'll kind of hook it in. like I say, I just cringe when I see bends. There's just, too many potential problems, but it's going to go there anyway. On all of your IAs, and particularly with a 30 gauge needle, with a 30 gauge needle, you can have as much as 50 degrees of turn. So if I'm trying to go in a straight line towards you and put my drug here, my needle ends up over here. So now I'm completely off target again too. And with the 25 gauge needle, that doesn't happen. It, pretty much goes in a straight line. When you're using certain C-clad devices and there's a rolling technique and it self-corrects, it goes in a straight line and the drug ends up truly being where we anticipate putting it. So just know if I want to manipulate my needle, you can do so by bevel opposite of where you want your tip to end up.
Excellent. Great hint. You are really full of great hints.
Yeah.
One of our attendees has noticed that when the patient is seated in an upright position rather than supine, the success rate is higher. Is that something you've noted?
No. But it may
Well, I mean,
be
if you're
that
injecting high in gravity and you're depending on
but it
gravity,
may be
it
when
makes sense.
when they have them up, they actually may be better on their angles. So where their target ends up may be better controlled when they have the patient positioned that way. Otherwise, that thing when we have them down, give the injection, and then the assistant's told to sit them up, let gravity help us. Just know gravity's not going to help you enough. And if you're already below the frame, and it's not going to help you at all. Otherwise, I think it's probably just a model of success that works for that individual.
Great. Okay, one more question here, because as a dental hygienist who is an expert in local anesthesia, I think you are uniquely positioned to answer this question. Okay. The Texas State Board is putting out guidelines today for hygienists to get certified to give local anesthesia based on a law from the legislature, and it will limit them to giving only terminal nerve ending anesthesia. To me, that would mean no nerve blocks, only infiltration.
Infiltration
Am I
only.
correct? And is this, what do you think about this?
I'm intimately aware of what's going on there, and I'm also currently intimately involved in helping Georgia. Georgia just got anesthesia for their hygienists. And a couple of things for anybody that has an opportunity to impact these decisions, we can very safely give all types of dental anesthetic injections. There's a huge body of evidence in the other 50 or 47 states that we do it safely, we do it well. So it's actually suppressing the benefit to the patients, the benefit to the practice when that happens. If they can only give it on children, doesn't help the greater good. If we can only do infiltrations, doesn't help the greater good. But if you are in a position where you are only going to be allowed to do infiltrations, still be excited you're doing something. And infiltrations with articaine can profoundly change the equation. And as you learn to make good selections and and map out your infiltration plan, we can be very effective, and particularly with the way articaine behaves. So I get their kind of sadness on one side, but also really encourage them to embrace where at least their starting point, and then hopefully the people with the power in those situations over time are going to go, wow, they really do know what they're doing. Let's expand that and start, broadening that benefit to everybody.
Amen. Amen. Well, Kathy Bassett, thank you so much for a wonderful lecture and bringing your expertise. We did not get to all the questions, and I apologize to everybody for that. But I know we scheduled for a second one, but we probably should do a third and a fourth, because we really want you to talk more about buffering. There's a lot of information that you can provide. And yeah, let's maybe we can even do an online series with you, because I think
there's
tremendous
excitement coming. Like I say, there's excitement coming. Lots of times we just have to wait till you get through Chicago midwinter. Lots of the companies, kind of divulge the up and coming things. So everybody, hold tight for Chicago midwinter and start being excited come the spring.
Well, thank you, Kathy.
Thank you.
Very good. And thanks everyone for joining us today. And thanks to the Business Advisory Panel. And if you join us next week, we're going to have Dr. Eugene Lee, who's a prosthodontist, and he's on our team here at Glidewell. And he's going to be talking about the overdenture option for implant prosthetics. So be sure to join us. And thanks, everybody. And thanks, Kathy Bassett. Take care, everybody. Bye-bye.